Hey, what up all my two doctors and doctresses? Welcome to another dental pharmacology lecture. Today we're going to be talking about cardiovascular system overview. It's the first lecture in the series of CVS. In order for us to understand the rest of the lectures, this lecture becomes the foundation. Created by Dr. Kanan Shah and presented by myself, Rishi Shah. So today's table of contents, we're going to go general overview of the entire CVS. Then we'll dig into blood flow, and then of course systole and diastole and heart muscle contractions. Then how ECG is produced, afterload, preload, mean arterial blood pressure. These are the composition of the blood flow that we will dig into deeper. Vasoconstriction and vasodilation, baroreceptors, and the sympathetic autonomic nervous system with renin, angiotensin, aldosterone system. These three mechanisms end up controlling blood pressure themselves. We'll figure them out in detail later. The factors affecting blood pressure, which then leads to what is hypertension, as an introductory slide to the next lecture, which is CVS2, so stay tuned for that, ending with references. So, this is our heart. We know what it looks like. However, did you know that death from a broken heart is possible? And it's actually medically diagnosed as the broken heart syndrome. So be nice to one another, guys. Spread happiness and joy. And without much ado, let's get on with the lecture. Heart, generally, it's a pump, right? It pumps blood, with arteries taking the blood away. So A for arteries, A for away. Veins would return, like venous return. Capillaries will connect and carry and connect, which means that when arteries take the blood to, say, for example, the kidney, the kidneys are provided the blood supply with arteries. Perfect. That's great. But kidneys so small. Arteries need little connectors that go all over the kidney to supply its entirety. And that's what capillaries do. They exchange gases. They carry blood supply to the smallest corners of the body. They connect different arterioles and so on. Then we have electrical nodes. The SA node and the AV node, and we'll dig into that later on. And of course, the lung and tissues are the primary focus when we're talking about the CVS supplies, because the lung allows for gas exchange and tissues allow for accepting the arteries and returning the veins. Okay, so like we said, we're going to dig into the blood flow deeper. Blood flow through the heart. So deoxygenated blood from the body, which means the blood that the body received from the heart is now used. The oxygen is now used. Therefore, it is deoxygenated blood. And this has to do with the right side. So, the blood, by blue, we mean veins. Okay? So, veins will return the blood to the heart. So, inferior vena cava receives the blood, transporting it to superior vena cava. Right atrium receives deoxygenated blood first from the four chambers, going through the tricuspid valve to the right ventricle. So right atrium to the right ventricle. And then right ventricle will then send that deoxygenated blood to pulmonary valve towards pulmonary artery, and then on towards the lung for being oxygenated. Okay. So basically what happens is our body sends the deoxygenated blood to inferior vena cava, which travels behind the heart to superior vena cava, and of course it also has its own blood coming in down into the right atrium. Right atrium then has to transport that blood to right ventricle. How does it do that? Well, it crosses tricuspid valve right over here. Once it does that, it travels from right ventricle through the pulmonary artery, crossing the pulmonary valve, and out through the pulmonary artery towards the lungs to become oxygenated. So we've covered the right side of the heart. Okay, let's move on to the second half, where oxygenated blood. Now it's become very, very clear that we went from here to the lungs. So now, the lungs need to send that blood back to the heart in order for it to be pumped throughout the body. So, oxygenated blood from the lungs to the left. Lungs, left. Lungs, left. Okay? So it travels through the pulmonary veins from the lungs to the left atrium, crossing the mitral valve on the way, left ventricle, through the aortic valve towards aorta, and of course the various organs of the body. So let's take a look at it on the diagram. Pulmonary artery to the lung. Lung oxygenated, all check. Now back to the heart using pulmonary veins, right? So away from the heart and venous return. So back to the heart. Now behind here you'll notice that it comes out through that hole towards the left atrium, filling it up and then crossing the mitral valve towards the left ventricle, and then that left ventricle's job is now to produce blood flow all throughout the body and supply all the organs, but first it needs to cross the aortic valve. And as it does, that red vessel, red being the arteries, aorta, and aorta then supplies it through the major arteries, then smaller arterioles, and then through capillaries, and finally the organs. Fair enough? That's the left side of the heart. Perfect. So that was how the blood flows through and from the heart. Okay, now let's talk about systole and diastole. First of all, whenever we hear these words, our first instinct is to go towards blood pressure. And that's fair. But systole and diastole is a motion of the heart muscle. So this is either going to be contraction or dilation of the muscle. So how does it work? Systole, squeezing of the heart. Systole, squeezing of the heart. It's for ventricular contraction, where pumping of the heart occurs. Right? Remember when we said that the left ventricle down here is responsible for sending all of that oxygenated blood to all throughout the body from the aorta. So how is it going to do that? Well, it's just going to squeeze from all directions. And when it squeezes, that ventricular contraction is referred to as systole. It's when the heart technically pumps. But there's a pressure that the arteries have to bear when flowing the blood. So imagine that all of that blood from here is now entering the aorta, and then through aorta all the way through the arteries. Let's understand how much pressure that those arteries have to bear. And that's what we call as arterial blood pressure value. In this case, because you need to understand that all of this blood needs to go to the heart and supply all the organs all entire lifetime, that number is going to be pretty high, right? So in the 120/80 typical blood pressure value, 120 is systole, the top number basically. And diastole. If the top number is systole, then the diastole is the denominator. Fair enough? And that's the 80 value. Now, let's find out where that occurs. It's the expansion of the heart. It's when the heart fills with all the blood and the heart muscles are relaxed. It's the pressure the arteries lose when heart fills up. The arterial blood pressure value in this case will be low and will be the bottom number. In other words, think of it this way. When all that blood is coming from the pulmonary veins, from the lungs, or in other ways, if inferior vena cava is sending the deoxygenated blood to the ventricles, in all senses, the heart is expanding itself in its ventricular spaces. Correct? Can we imagine that? Well, perfect. In that case, could you imagine the arteries? They're all free. They have nothing to do. So they're relaxing. It's their break time. In that time, the pressure produced in the arteries goes down from 120 to 80 in, of course, ideal scenario. But that reduction leads to a value known as diastole. It's the denominator. Okay? So, systole, squeezing. Diastole, relaxing. Perfect? Awesome. Now let's dig a little deeper. Remember, at Tooth Factory, we do the bottleneck approach to any videos, any lectures, and we went from what a heart is to what systole diastole is, and now we're digging deeper into each arterial, ventricular, and so on and forth. Okay, so bottleneck approach. Let's talk about arterial systole, ventricular systole, and then diastole in general. So arterial systole, it's when chambers, blood flow, and valves need to be taken account because those are the physiological parts of the heart. In terms of chambers, in arterial systole, we know that systole means to squeeze. So the atrium is going to contract. But at that time, the ventricles are relaxed. So don't let this fool you guys. Every chamber has its systole. Every chamber has its diastole. In this case, in arterial systole, that's when atriums contract, atriums squeeze, and ventricles are relaxed, which means that all that blood from the atrium is squeezed out through the valves towards the ventricles. And ventricles are relaxed because, well, they're filling up with blood. So, blood flow from atrium to the ventricles. And what valves are open? We got AV valves that are open. AV valves are located right here. And what do they stand for? Atrioventricular, which means from atrium to ventricle. From atrium to ventricle. And they're open, right? Blood moving from atrium to ventricle. But the aortic valves are closed, which means this valve right here, they're closed. Because the blood can't leave the heart, we have to fill that ventricle. Perfect? So that's atrial systole. Similarly, ventricular systole is when atriums are relaxed and ventricles will contract. The squeezing of the ventricles, where ventricles send blood to aorta. In this case, the atrioventricular will be closed. And what will be open? Aortic valve. So that the ventricles can send that blood out and supply the organs. That's ventricular systole. Diastole, on the other hand, is very, very simple. It's when both chambers are relaxed. Basically, the heart relaxes. Heart has nothing to do with diastole. It relaxes. It just fills up with all that blood. So, blood flow back to the atrium and ventricle. It's when the entire heart is filling up with blood. It's when AV valve is, of course, open and aortic valve is closed because the heart is filling up. So the outgoing flow, aortic valve, is closed. But the AV valve is open. So we need to understand that diastole is the denominator value, 80, and systole is the numerator value, which is 120. Now, just as a little summary, because we need to talk about the valve so much in this case, that brings us to talking about heart sounds. The first heart sound, known as the lub, right? So we got lub, that occurs when atrioventricular valve closes. So when these valves close, so basically all that blood from the atrium decides to fill the ventricle, and ventricle says, okay, I have enough blood now. Can you please close the valve? I cannot tolerate more blood. So the valves here, atrioventricular, they close, right? Right here. During ventricular systole. That's when we produce the first heart sound known as lub. So ventricular systole. The second heart sound known as dub, lub dub, that's our heart sound, occurs when the semilunar valve close. And by semilunar valve, for example, aortic valve is a semilunar valve. It's when they close, for example, during atrial systole. So, atrial systole. And that's when dub is produced. So lub dub, lub dub, lub dub. It's when ventricles contract, all the blood out, and now we have aortic valves closing. Fair enough? Perfect. That's lub dub. All right. Now let's talk about contractility of the heart. We understood how the blood fills up and the atriums and ventricles and so on, they contract and relax and all. But what actually creates that muscle movement of the heart? So in general, we know that muscle movement is produced by electrical charge, right? What kind? Especially in the heart. There's sinoatrial node, and by node it means there is this one location that produces the electric charge. Sinoatrial, SA node, atrioventricular node, AV node, so SA, AV, and Purkinje fibers and bundle of His. Okay, so this is our electric circuit in the heart. First of all, with all the reactions from the brain, the sinoatrial valve generates an electrical signal, a very minute charge that causes atrium to contract. So here it is, SA node. It produces an electric charge that ends up contracting the atria. Okay, now what happens when they contract? Well, we have this valve opening up, all the blood flowing down, ventricles filling up. Now what happens when ventricles fill up? They need to contract, they need to get rid of the blood. That's when AV node is activated, and that AV node's location is right here between atrium and ventricles. It's a relay of electrical signals. It will rally the SA node signals through the entire heart, causing ventricular contraction. What happens in ventricular contraction? It lets the blood from the ventricle exit using these semilunar valves, such as aortic valve in the case of left ventricle. Fair enough? Perfect. Then what's these? What's Purkinje fibers and bundle of His? They're actually a bunch of tiny little fibers, or appendages, if I may, that cause synchronous rapid contractions of the ventricles, which means the synchronicity with which the heart needs to contract itself in various areas, such as atrium and ventricles. Purkinje fibers take care of that. And they're located in the ventricular muscles themselves. So the appendages down here, they allow for both sides of the heart to have a synchronous rapid contraction. And those are known as Purkinje fibers. Okay, so if I were to be a little bit more specific, you guys, Purkinje fibers are right here at the bottom, and bundle of His is actually here. So if we were to go using our chronology, we would go SA node, then we go AV node, then we'd go His, then it would be Purkinje. Fair enough? Perfect. So how does that get recorded? It gets recorded using an ECG, electrocardiogram, and into a cardiac rhythm that we can call as PQRST wave. Fair enough? Okay, so what's the P wave? By the way, before we begin this, I do want to mention that depolarization means to be active. It means to send charge over, okay? In other words, contract, okay? Because when electric charge is sent, muscle is active, it's going to contract, okay? So let's keep that in mind. P wave. P wave is the depolarization of atria. Atrium is the first thing to be contracted, right? So P wave is contraction of atria. And then there's a little bit of a gap. Now we have QRS. So we have QRS wave, and that's the depolarization of ventricle. Very simple, right? Contraction of ventricles. And then we have a long area here with T wave, and that's the repolarization of ventricles. In other words, it's the relaxation period for ventricles. It's filling with blood, right? So this is now going to be a relaxing of ventricles. Is that easy to understand, guys? That in terms of PQRST wave, we have P, we have QRS, and we have T. Perfect? Awesome. And this is just a way to read the chart on this side, that this is known as the PR interval, which means the time that's spent from beginning of the P to the beginning of the R is known as the PR interval. And PR segment is the plateau here where there is a consistent activity, not no activity, a consistent activity. And then Q and T interval between Q and T. S and T is between S and T. And the segment, the term segment is used when there's consistent activity between S and T, and R is known as a complex. So, for example, if we were to break this down here, what do you think is happening in the ST segment? For example, well, in the ST segment, we know that there is a repolarization of ventricles, right? That, in other words, is blood is filling in ventricles. Fair enough? Let's try another one. What's happening in the PR interval? Well, in that time, we have depolarization of atria. So basically, blood is leaving atrium and filling the ventricle. Awesome? Perfect. So, talking about the cardiac muscle action potential, let's dig into something deeper, which can be a very, very good question for an exam. It's divided into phases, guys. It's divided into 4 phases and then addition of phase 0. So, it's a 5-step procedure. Okay? Cardiac muscle to be potential in its action. What's phase 0? Phase 0 is sodium channels open up and sodium moves inside. Remember, the central nervous system plays a big role, a really, really big role in giving this an initiation. So phase 0 is sodium channels open up and sodium moves inside. Okay, so let's read this section here. It says that there is a fast upstroke. Sodium channels open, those are known as fast channels, resulting in a fast inward current, so sodium moves inside, and upstroke ends at sodium channels when they're rapidly inactivated. So it's just very quick. So we know that this section is very quick. When sodium moves inside, it creates an action potential charge. So on the graph right here, what we have is 2 variables in the x-axis and in the y-axis. X-axis, we have time that it takes, and y-axis is the action potential measured in millivolts. Okay, so it's the electric charge. So when it's resting down here, when it's inactive, it's usually at -70 millivolts. Okay, resting potential. And all of a sudden, really fast, all this sodium moves right through the membrane inside the cell, and the channels then close. That positive charge, right? Remember, this is a negative value. Now we're adding sodium, which is positive, which means that phase 0 leads to a surge of electricity towards the positive charge of about +20. Okay? About +20. That's how much it added. Millivolts. Now, sodium current is now blocked by various drugs, such as antiarrhythmic agents, such as quinidine. Okay? Sodium channel blockers are the first class in antiarrhythmic drugs, and we'll take a look at that in our CVS second lecture. Okay? Is this so far clear? Okay, so I'll get rid of some information so it's easier for us to understand here that phase 0, all we can tell is that sodium is added from -70 towards +20, causing an action. Okay, I'll change the color here so we can understand things even better. Now we're moving to phase 1. Phase 1 is rapid repolarization, initial rapid repolarization. What does that mean? Well, the body realizes that, oh my God, there's a lot of sodium coming into the cell. We need to stop this. It's way too high. So there's a rapid repolarization, which means, remember that when in our previous lectures we said polarization means to create a negative charge. So repolarizing it a little bit, right? But it's rapid repolarization is when sodium channels are closed and potassium channels open and close. So now potassium is working. So sodium and potassium move outside, causing a negative charge inside, but not that much, just a little bit, maybe towards 0 millivolts. Okay? So in other words, this goes from negative 70 to positive 20. This goes from positive 20 to 0. Fair enough? So let's read this. It's called partial repolarization. Remember, it's partial. It's not entire. It's partial. The initial rapid phase of repolarization is due to inactivation of sodium channels. So sodium channels close. Potassium channels that are rapidly opened and closing, they cause a transient outward movement. So sodium blocked. Potassium opening and closing, leaving the cell, causing an outside cell accumulation of potassium. And that's phase 1. It brings the charge a little bit down. Okay, now let's move on to the next color. We have phase 2. It's the plateau stage. Plateau means flat. No movement. It's just almost less steep. Okay, so plateau stage. It's when calcium channels now open up. Slow calcium moves inside, so it's slow this time, hence plateau. Slow potassium leaks outside, so there's a balance between potassium and calcium. But because of that, there's not much of a change in the electric charge. So it's right here. From this point to this point is phase 2. It's known as the plateau, where voltage sensitive calcium channels open, resulting in slow inward movement, causing depolarization. Remember, when calcium enters the cell, it causes depolarization because it's a positive ion. But the current is balanced when there's a slow outward movement of potassium. So potassium leaves outside the cell, causing a little bit of a negative charge. So there's a balance between the two charges, causing plateau. Right, so no change. Perfect. So far, what have we seen? We've seen that this is sodium. We saw that this is sodium and potassium. This is calcium and potassium. So now what's going to happen? Well, let's find out. In phase 3, there's repolarization. So the charge is now consistently dropping. It's when calcium channels close and potassium channels open. Therefore, potassium moves outside the cell, causing a negative charge, negative 70. Perfect? So number 3, from here to here, it drops the charge. This is why it causes a negative charge built up inside the cell. Therefore, we call it repolarization. So calcium channels close, so calcium is not allowed inside the cell. Potassium channels open, resulting in outward current that leads to the membrane repolarization. So all that potassium leaves the cell and causes a negative charge to be built inside the cell. The net result of action to this point is not gain of sodium, and there's a lot of loss of potassium. This imbalance is corrected. Okay, so now this negative charge is then later corrected by sodium potassium ATPase. So very important point that in phase 3 repolarization of the cardiac muscle action potential, what corrects the negative charge imbalance? The answer is sodium potassium ATPase. Right? Perfect. How does it do that? The answer is correct, but how does it do that? Well, there is a slow sodium that moves inside, causing an increase in depolarization, which means causing a little bit of a positive charge, and then it propagates the signal because a little bit of positive charge, which means it'll attract more positivity. And that's from here to here. So how it moves up a little bit slow in phase 4. It moves up towards the positive. So this is known as the forward current. Increasing the depolarization results from gradual increase in sodium permeability. The spontaneous depolarization automatically brings the cell to the threshold for the next action potential. And what's the threshold for next action potential? -70. So as soon as it hits that, there's more sodium coming in. Because of this, it propagates the signal in phase 4, and now we have phase 0 again. Okay, that entire thing will end up contracting one contraction of cardiac muscle. So how long does that take? Let's take a look. It takes, in seconds, 1. That whole process is only 1 second, and the cardiac muscle contracts. Fair enough? Is the chemistry clear in that? Perfect. So here's a larger diagram for us to pause here and make these notes. This is an action potential summary of the previous discussion. So repolarization means inactivation of the cell. So completely negative charge, no activity. Depolarization is activity of the cell, so moving the charge towards positive. Main ions in question are sodium, potassium, calcium. Perfect. The voltages, so there's an E here, sorry about that. Voltages summarized. -55 is our threshold where phase 0 takes place, going up. +40 is the action potential depolarization. So it goes all the way up to 40, and then -70 is the inactivation of the cell, and then it drops towards -70. Leads to -90, which is hyperrepolarization. Okay, so if somebody asks what is the threshold for action potential of a cardiac muscle, the answer is -55 millivolts. What is inactivation or resting potential? It's -70 volts. When does it start to hyperrepolarize? Where does it end at? Well, it's 20 below resting, and it's hyperrepolarization. Hyperpolarization. Fair enough? So, in all importance, all ions involved are positively charged, right? All of these are positively charged. Therefore, sodium, potassium work to manage the charges inside the cell, and calcium is the one that is responsible for muscle activation. Now, why did we say that? Well, think of it this way. Over here in this phase, in repolarization, we figure that potassium leaves and causes a lot of negative charge, all the way down to, say, -90, right? In hyperpolarization, for example. Well, in that case, sodium potassium ATPase, they manage to work the charges. Calcium has nothing to do with that. So, sodium potassium ATPase work the charges, but calcium causes cardiac muscle contraction. Perfect? Cardiac muscle contraction is calcium. Okay. Let's move on to another diagram that explains ionic movements that we just talked about. So we're looking at sodium, potassium, and calcium. Okay, so this is the membrane of a cardiac muscle. There are 3 channels. We got voltage sensitive slow calcium, we got sodium calcium, and we got sodium potassium ATPase. Okay, so step 1. Calcium entry from outside the cell triggers the release of a much larger quantity of calcium from the sarcoplasmic reticulum. Okay, so when the calcium moves inside slowly inside the cell, now this is inside the cell and this is outside the cell. The calcium stores, which is in the sarcoplasmic reticulum, causes all these free calcium to be hitting the myofibrils. The increase in calcium concentration initiates a contraction process in the myofibrils. So calcium comes in, releases all these calcium. That free calcium goes to the myofibrils, causing a contractile motion. Now, once it's done, the calcium is removed by reuptake into the sarcoplasmic reticulum and by extrusion from the cell by sodium and calcium exchange. So calcium is done its job over here, comes back here, changes its position with sodium. Fair enough. Now sodium is inside. Sodium being a lot more inside, it needs to be balanced by potassium because it's way too much sodium inside. Therefore sodium leaves, potassium enters, and that is the balance restored by sodium, potassium, ATPase. So that's how the sequence of ion changes occurs. Calcium comes in first. Free calcium causes muscle contraction. Calcium has done its work, so it leaves. In return, sodium comes in through sodium calcium exchange, and then too much sodium into the cell, causing the sodium potassium ATPase to work and balance out the potassium inside by causing sodium to leave. Perfect? Awesome. So now let's talk about terminologies that affect blood pressure. Okay? Preload, afterload. What's preload? Well, preload is volume of blood in the ventricles at the end of diastole, end of diastolic pressure. Okay, what does that mean? Do you guys remember what diastole was? Diastole was the denominator. It's the 80 of the 120. It's when all these ventricles are completely relaxed. All the atria are completely relaxed. They're not contracting, they're filling with blood. So the volume of blood in the ventricles at the end of the diastole, when all that area is filled with blood, it's known as end diastolic pressure. End diastolic pressure. That's preload. What does that do? Well, it ends up increasing hypervolemia, regurgitation of cardiac valves, and heart failure if not corrected. See, all of these are sequential events. Preload needs to turn into afterload and so on and forth. If it doesn't, it will lead to hypervolemia, regurgitation of cardiac muscles, and heart failure. But thankfully, we have afterload for it. It's the resistance left ventricles must overcome to circulate blood. What does that sentence mean? Basically, all of this ventricle that is filled with blood, that is trying to pump it out all the way through the aorta and out towards the body, well, that has a resistance, right? Cardiac muscles have a limitation. They can only expand so much, they can only contract so much. So to let go of all that blood, the bulge that is created in the arteries, in the ventricles, in the aorta, is the afterload. Specifically in the left ventricle, because the left ventricle is responsible for sending the oxygenated blood to the body. But that resistance must be overcome by a pump action, right? And then that leads to blood flowing out through narrow arteries out to the body, right? So ventricles are really thick, aorta is a little bit thinner than ventricles, and then arteries are even more thinner, and then capillaries are even more thinner. So all of that diameter that reduces itself leads to afterload. But if not compensated, what happens? That's when hypertension happens. That's when vasoconstriction happens. Therefore, for afterload to be corrected, cardiac workload increases. So increasing afterload means increasing cardiac workload, which is systole. Systolic blood pressure. It's the contraction. Okay. So let's take a look at this chart here. The blue is a family, the red is a family, the green is a family, and the Orange is a family. Okay, let's take a look. Mean arterial blood pressure, MAP, commonly known as BP, blood pressure. So we just talked about afterload, we spoke about contractility of the heart, we spoke about preload. All of that has effects on myocardial fiber shortening. In other words, the pumping action of the heart. But that's not the only thing. The size of the heart also matters. So left ventricular size, basically how big your heart is, leads to how much you can pump. So this family right here has to do with pumping. This family right here has to do with blood flow in heart. Contraction of the heart, afterload in the heart, preload in the heart, and so on. So when the blood flows to the heart, it ends up pumping, causing a heart rate that we can measure with beats per minute and multiply that with stroke volume. Stroke volume is basically the amount of blood pumped through the heart by the factors of the size of the left ventricle and the actual fiber shortening of the cardiac muscle. When you multiply the heart rate with stroke volume, you get a value, and that value is cardiac output. Okay, stay with me here. We'll clarify this as well, okay? So don't worry. When you multiply heart rate with stroke volume, you get cardiac output, and cardiac output is a factor in measuring blood pressure. The other factor is peripheral resistance. The heart has sent the blood out. That's perfect, great. But what about the arteries in the periphery of the body? All over the body. Arteries, vessels, arterioles, capillaries, things like that. They have to resist a certain amount of blood flow. They can only pump a limited amount of blood within a certain amount of time, right? And that is known as peripheral vascular resistance. When you multiply that with the value of how much blood has been pumped out, which is cardiac output, now we get blood pressure, systole and diastole divided, right? So, huge equation, but now let's break it down because we know what everything means. Afterload, contractility, preload causes myocardial, so basically muscle pumping, it pumps, right? Shortening. And then, of course, the size. They both are associated with stroke volume. Okay, so now we have stroke volume. And, of course, heart rate is produced when we measure it. When you multiply the two, you get cardiac output. Cardiac output is basically just how much heart has poured out into the peripheral system, but the peripheral resistance, or PVR, is how much the arteries are willing to resist while flowing the blood, causing a value that comes out as BP. BP is also known as systemic vascular resistance. The role is of arterial pressure and PVR and how they're connected. It constricts the peripheral blood vessels, right? That's the resistance. The consequence is the creation of blood pressure. Factors that influence the peripheral vascular resistance are blood viscosity, how thick the blood is. So now when we think about blood viscosity, things like aspirin comes into our mind, anticoagulants like warfarin comes into our mind, things like that. Sympathetic activity, which is sympathetic autonomous nervous system. Now we're talking about the beta activation, alpha activation, adrenergic system, right? And we've talked about all of these guys. And of course the vasoconstricting drugs. So in pharmacology, we got a lot of vasodilators and vasoconstrictors. Vasodilators would have been things like the calcium channel blockers. But in terms of vasoconstrictor, we have epinephrine, right? It increases the peripheral vascular resistance. It's a vasoconstrictor. Perfect. So this chart is clear, you guys? Awesome. Mean arterial blood pressure, MAP or BP. So this is so much more simplified. Blood pressure cardiac output, stroke volume. Three of the most important numbers when it comes to CVS. We'll go from the bottom towards the upper one. Stroke volume is N diastolic volume minus N systole volume. Okay, EDV minus ESV. Now, we don't need to dig much deeper into this, but we just need to know that it has to do with how much volume of blood has been pumped out of the heart. Okay, cardiac output, we got stroke volume multiplied by heart rate, which is beats per minute, specifically measured clinically. And then when cardiac output is achieved, we multiply that value with PVR, and PVR is basically what the vessels offer, and we get blood pressure. So, blood volume, venous tone, right? Venous is blood coming back, so diastole. Blood volume has to do with how much volume is in the heart to be pumped out, which is systole, right? When all of that is gone up, there's a filling pressure in the ventricles, which is then contracted, and we get a heart rate. All of that towards cardiac output. When you multiply cardiac output with peripheral resistance caused by arterial tone, which is vessels, we get blood pressure. Now, these are like three different ways we just explained blood pressure. So hopefully the concept is clear in periphery, but if you have any questions, please reach out to us in the comment section or on our page. We will be able to answer all your questions. Moving on. Vasoconstriction versus vasodilation. So we kind of hinted upon this. Let's dive in a little deeper. Let's first take a look at the diagram here. This is a normal blood vessel, blood flowing through. Beautiful. However, when the walls of that artery or the vessel is thinned out and the lumen is expanded, that's when we have vasodilatation or vasodilation. When the lumen is shortened, we get vasoconstriction. Well, how can these happen? What factors produce it? What are pathologic factors? What are circulatory factors? Let's find out through this chart. First, we'll talk about vasoconstriction. So, in vasoconstriction, what are the local factors? Decrease local temperature. So, if your body is getting cold, your body will instantly start constricting the blood vessels. And autoregulation. In other words, when there is vasodilation, the body tends to activate the sympathetic autonomic nervous system, causing alpha 1 to be active, leading to vasoconstriction. For more information, please review our adrenergic system and you'll understand the mechanisms behind it. In endothelial products, so these are basically various types of chemotaxis or chemoreceptors and molecules and hormones and other molecules around the body, basically, such as endothelin 1, locally released platelet, serotonin, thromboxane A2. All of these are responsible for actually closing the lumen as an endothelial product. So, I'll take an example. Thromboxane A2. Do you remember it from our NSAIDs lecture? It is a production of clot, and that's thromboxane A2. It actually produces a clot. Another thing is platelet. Platelets accumulate over here at the edges, and they constrict the blood vessels and blood flow. Or in other ways, for example, if you have an injury, how do you stop the blood from flowing out? You constrict that lumen. So naturally, endothelial products such as, well, platelets and thromboxane A2, they take care of that. What are circulating neurohormonal agents, which are vasoconstrictive? Epinephrine is one. Norepinephrine. We got angiotensin 2, and that's what causes increase in vasoconstriction, increase in BP, and that's why one of the drug classes in BP or hypertension treatments is angiotensin 2 blockers, angiotensin receptor blockers, known as ARBs. So when we block it, no increase, and blood pressure is decreased, basically treatment of hypertension. So in reversal, vasoconstriction is caused by angiotensin 2. And then endogenous digitalis-like substance. So digitalis is known as a contractile. We'll take a look at that much deeper in the antiarrhythmia lectures. We got digitalis or digoxin, for example. It causes a contraction of the heart, but our body also has endogenous digitalis-like substance and neuropeptide Y. We don't really need to know this, so don't worry about this. And then neural factors, which is CNS. How does the central nervous system play its role in vasoconstriction? Increased discharge of sympathetic nerve. So remember, from the adrenergic system, sympathetic autonomic nervous system, also known as adrenergic system, when that is activated, we have vasoconstriction through alpha 1 and beta 1. Perfect. So that was vasoconstriction. Now let's take a look at vasodilation. When there is increased carbon dioxide and a decreased oxygen, that's when vasodilation happens. Because think of it this way, or remember it this way, our body wants more oxygen to breathe, right? So it's going to dilate the blood vessels, causing more space to be available so we can seek oxygen from anywhere. So if the oxygen is reduced, that's when our body says, oh, I gotta dilate my blood vessels, I need more oxygen. Fair enough? Good to remember? Awesome. Increase in potassium, adenosine, and lactate. So these are just local factors, right? So we got potassium increase, adenosine and lactate increase, causing vasodilation. Decreased local pH. So if the environment is acidic, that's when vasodilation takes place. Now, I just want to make this clear because in the future, we will come to a lecture of alkalosis versus acidosis. So keep that in mind. We will come with this lecture. Acidic, decrease in local pH is increase in CO2. Okay? Just keep that in mind. Moving on. Increase local temperatures. Opposite of this. So when you have a fever, basically, more areas need to be given blood supply. In order for them to do that, we have vasodilation. Endothelial factors, we got nitric oxide, kinins, and prostacyclin. Remember, the rival of thromboxane A2 was prostacyclin. It caused bleeding, and all of this information, guys, is available in our NSAIDs lecture and our pharmacology lectures in pharmacodynamics and kinetics as well, so please take a look at those videos as well. Prostacyclin led to bleeding. Remember, nitric oxide or nitroglycerin compound, for example, causes vasodilation. Remember, treatment of myocardial infarction, and more lectures coming up on that. That's why we said that this lecture is a foundation for the rest of the CVS lectures as well. So keep all these in mind and in your notes as well, guys. Moving on to circulating neurohormonal agents. We have epinephrine in skeletal muscles and liver. When epinephrine enters skeletal muscles and the liver, it actually causes vasodilation. It's just a fun fact. Not much relevant for dentistry, but it's a fun fact. Calcitonin G-related protein, substance P, histamine, and atrial natriuretic peptide. Vasoactive intestinal polypeptide. So what's important, what's not important? For us, histamine is very important. Okay, let me correct that. Sorry about that. Histamine is very, very important for us. Substance P, not important. This protein, not important. And these are polypeptides, are not important. So histamine. What happens during histamine? Remember, guys, when you have an allergic reaction, what do you first get? Red skin, rash, flush, right? That's because histamine is released. IgE mediated response of the body. Remember, IgE mediated response. Histamine causes vasodilation. Perfect. Neurofactors of vasodilation. Decreased discharge of sympathetic nervous system. So inactivation of sympathetic nervous system, also known as, say, beta blockers or alpha blockers. When alpha is blocked, vasodilation takes place. Very simple. So activation of beta 2 adrenoreceptors on the vasculature of skeletal muscles and the limbs. This is an exception. So beta 2 actually causes vasodilation. So again, pharmacodynamics, pharmacokinetics, and our adrenergic system. Beautiful explanation, guys. Please do check them out. Okay, baroreceptors. So remember the words that I write here. Reflex, pressure, sensor. Okay? Why are these words important? Well, baroreceptors. Baro means pressure. Receptors are sensors. What will they do? They will cause a reflex response. Okay, so for example, baroreflexes are parts of the sympathetic nervous system, sympathetic autonomous nervous system. They lead to a rapid regulation of blood pressure. So their job is to actually maintain blood pressure in the body. The locations of their areas are aortic arch and carotid sinus. Aortic arch and carotid sinus. Okay, two locations. So what happens? Well, take a look at this sequence over here in the diagram. This is our brain stem and the spinal cord. Okay, and this is our carotid sinus, basically the arteries in our neck. Right over there, there is a carotid sinus in the Y section there. One of the baroreceptors is sitting there. So think of it this way, that when arterial pressure is low, the baroreceptors pick that up. They sense it. And all of that information is transmitted through the sensory fibers all the way to the nucleus of tractus solitarius. And that's over here in the brain stem. That information is then relayed to vasomotor sensor, which is inferior to its location, and then autonomic ganglion, and ganglions are basically a relay center to the specific part. So it's like a airport terminal where this flight comes in, lands here, and then connecting flight goes, where motor fibers are now activated with sympathetic nerve endings at the site, which means these receptors will be alpha and beta receptors. Where is this located? It's located in the heart, the blood vessels, all those places that have the capacity to increase the arterial blood pressure. So when this happens, the blood pressure is no longer low, it is high. And the baroreceptors then send that signal back, bring it down here, autonomic ganglion, sympathetic nerve ending, and alpha and beta receptors are blocked, causing a decrease in blood pressure. So that's their job. They regulate blood pressure very rapidly. Okay, so low blood pressure, less impulse is sent to CVS by baroreceptors, and that leads to the brain saying, oh, I have inhibitory neurons sending signals. I need to tell my vasomotor sensor that I need to increase sympathetic activity. How is that going to do that? Well, the first flight is going to take off from vasomotor sensor. It's going to reach to the ganglion. Connecting flight of motor fibers will take its site to sympathetic nervous system endings, and it will increase the sympathetic activation and decrease the parasympathetic activation. At the end of its cycle, vasoconstriction will take place at the alpha-beta receptors, causing an increase in the cardiac output, leading to an increase in blood pressure at the end. That's what baroreceptors do, and their locations are aortic arch, carotid sinus. And then the last big cycle contributing factor to blood pressure maintenance is the RAAS. Okay, we will discuss so much more in depth in the hypertension lecture, but just an overview. This is the body's mechanism of controlling the blood pressure using a different section of the body. So, the blue section here versus the red section here. The blue section is when there is increase in sympathetic activity. And the red section has to do with our kidney. Okay, so this section is CNS and this section is kidney. Okay, so when there is low blood pressure, then sympathetic nervous system activates. We know how, right? For example, baroreceptors, beta, alpha, things like that. Activation of beta 1 adrenoreceptors on the heart itself. When they're activated, cardiac output goes up, causing increase in blood pressure. Simple. When sympathetic system is activated, there is also activation of alpha 1 adrenoreceptors on smooth muscles, such as vessels, and they cause increase in venous return, increase in peripheral vascular resistance, leading to increase in blood pressure. Fair enough? When sympathetic nervous system is active, there is also activation of beta 1 receptors on kidneys. And that's the connection between the CNS and kidneys. When beta 1 is activated on kidney, there's increase in renin production. Renin leads to increase in angiotensin 2. Angiotensin 2 increases peripheral vascular resistance. It's a vasoconstrictor, very, very strong vasoconstrictor, just like epinephrine. And that PVR then leads to increase in blood pressure. Perfect? Now the other side of the coin is down here. When there is low blood pressure, the body responds by saying, hey, I have less blood flowing to the kidneys. Decrease renal blood flow. And then the glomerular filtration rate also drops. Okay. In response to that, sodium water retention is taken place. And that is the RAAS system. Sodium water retention takes place. Sodium water retention is in relation to aldosterone. Remember when we said that angiotensin 2 is a very strong vasoconstrictor? Well, it also offers an increase in aldosterone. And aldosterone increasing also contributes to increase in sodium water retention. Ultimately, the blood volume increases, causing an increase in the blood pressure. Okay, so let's talk about how anatomy plays a role in blood pressure control. Basically, it's a summary of everything we just talked about. You know that the center is the sympathetic autonomous nervous system. It declares a lot of instructions to various anatomies. For example, there's resistance of arterioles. That controls the blood pressure, right? The response is then sent to the venules back to the heart, which controls the cardiac output. And that cardiac output then towards the body has to do with how the kidney is associated. So if the volume of kidneys is reduced, the renin is going to be increased, leading to angiotensin production, aldosterone production, sodium water retention, and then increase in resistance of the arteriole. So PVR is increased. So we have this sympathetic autonomous nervous system, heart in function, kidney in function, and back to peripheral vascular resistance that controls the blood pressure. If this is positive, sympathetic nervous system is going to be negative. If this is negative, sympathetic nervous system is going to be positive, and hence there will be either response on each side. Fair enough? Perfect. So hopefully that anatomical picture clarifies a lot of doubts for us for blood pressure regulation. Okay. Factors that affect blood pressure. We got non-modifiable factors and modifiable. Non-modifiable means some things we don't have control over: age, gender, genetic factors, and ethnicity. Modifiable factors such as obesity, so our body weight, and fat deposition and so on, with salt intake in the diet, potassium intake, saturated fats in diet, alcohol and smoking in habits, stress, physical activity, and socioeconomic status. All of these can lead to variations in the blood pressure. Now this chart over here has to do with what blood pressure can lead to. So these are conditions. Blood pressure can lead to angina, diabetes, hyperlipidemia, heart failure, previous myocardial infarction as a risk factor, and renal impairment and asthma. So, percentage of hypertensive patients with indicated concomitant disease, which means frequency of occurrence of other disease among hypertensive patients. In other words, if there is a patient with hypertension, then they're very likely to get angina, particularly 15% of those patients. 12% of the patients get diabetes. 7% of the patients have asthma. Almost 10% have renal impairment, and 12% have about previous myocardial infarction. Heart failure in about 13% of the patients, and that's how severe hypertension is. Therefore, this section of the chart, modifiable factors, become the most important treatment measure that is non-pharmacological. And then we step into the pharmacological aspects, which is going to be discussed in the next lecture. This is the introduction to hypertension. So what is hypertension? It is sustained. So the word sustained is very important. Sustained increased systolic blood pressure above 140, so 140 plus mmHg, or increased diastolic blood pressure above 90. So whichever value comes first, whether it's systole or diastole, it is going to be classified as hypertension. Okay? So diagnosing a patient with hypertension, we must record the blood pressure of 140 over 90, whichever value comes first. What are the different causes of hypertension? Physiologic causes are increase in peripheral vascular resistance, increase in smooth muscle tone, renal artery constriction, pheochromocytoma, that's a tumor of the adrenal medulla, aortic contraction, hyperthyroidism, Cushing's syndrome as a worst consequence of that. Two types of hypertension. There's primary or essential, there's secondary. Primary or essential has no etiology. It just happens, unknown. But secondary is the one that actually has a cause. So if all of these caused hypertension, then we can classify it as secondary hypertension. But if it just happened and we happen to detect hypertension, there's no etiology that we can assign it to, then it's primary hypertension. Then there is something known as white coat hypertension. It's just a transient increase in blood pressure in the presence of a doctor. Hypertension as a risk factor. Majority of the cases are stroke, angina, MI, congestive heart failure, and chronic kidney disease. Sorry about it not being seen well. But all of these diseases, systemic diseases, can be caused in the presence of hypertension. And guess what? Each of these is a lecture on its own. So stay tuned with us for more CVS lectures. And before we let you go, I'm just going to show this little chart here with the different values and classification of hypertension for the next lecture, so everyone is fresh reading it. Systolic and diastolic values. Normal is less than 120 and less than 80. Remember that, guys. Less than, not equal to, less than 120 over 80. Pre-hypertension is including 120 all the way up to 139 systolic, including 80 all the way up to 89 in diastolic. Stage 1 is now hypertension, not pre-hypertension, it is hypertension, diagnosed hypertension, with, of course, sustained increase. So 140 to 169 or 90 to 99. Remember, this is any value that comes first. Stage 2 is more than 160 or more than 100 in systolic or diastolic. Okay, so one little trick to remember all of this, and we'll discuss this in the future as well in the next lectures, is the systolics, they increase by 20. Diastolics, they increase by 10s. Just a little shortcut, doesn't always apply, but it helps. For example, 80 to 89, 90 to 99 plus 100. So 80 to 90, 90 to 100. they increase from prehypertension to stage 1 to stage 2. Systolic, we have 120 to 140 to 160, increase in 20. Okay, just a way to remember the numbers. Okay, so thank you for staying with us for so long, and hopefully this lecture gives us a foundation of our next few CVS lectures. Our resources are placed in the description box below. It is now a membership of the Tooth Factory's Dental Library. So please visit our website and you'll find out more with regards to our resources and how you can access them. Thank you for watching. Stay tuned for more CVS lectures and more dental-related full-length lectures on YouTube. Please visit us on Facebook and Instagram if you have any questions, as well as our blog website. The links are in the description box below. And if you have any questions, please email us. And again, it's all in the description box below for your information. Thank you very much. Have a great day and stay tuned for more lectures.